for anything that would get in my way.
Okay. All right. Thanks everyone for coming, and huge welcome to thank you for coming and helping our group out and teaching us about emergency department protocols. So as you know, we're Anaphylactic Food Allergy Support in New Mexico, and we haven't had a presentation like this, so I'm really excited. There are lots of questions kind of floating around on our Facebook group about what do you do, what do you do? So we have Dr. Skarbek-Borowska, who's attending physician at, or assistant professor of the ER medicine at UNM. And you, in 2014, you became the assistant program director for education and then the pediatric emergency fellowship. And so thank you so much for being here. And Dr. Matt Gunderson is one of the fellows in the program. And Lisa and I met with these two in April, like a year ago, around a year ago, after her son was visited the ER. So anyway, we just really appreciate the support and the knowledge that you're giving back to our community as far as all the changes you're trying to make, have been implementing. So thank you. And then Sarah Davis is certified nurse practitioner who was at the pediatric ER for many years, supervisor nurse, and now is with the UNM trauma service. And she has 3 kiddos with anaphylactic food allergies. So she's an expert. So we appreciate that you can speak from kind of both sides.
Absolutely.
It's really nice to have that perspective. So thank you very much. Take it away.
Thank you for having us.
Yes, thanks for asking us to come tonight.
Yeah.
We have some slides to guide our discussion, but please feel free to stop us at any point and just give us any questions that you have. So we wanted to just talk about anaphylaxis from the emergency room perspective. So we're going to talk about triage. We will then move on to the new pathway that we have just implemented to help improve the care that we provide to children with anaphylaxis. And we'll talk about the goals of that. We want to spend just a few minutes talking about some of the myths about anaphylaxis management. And then beyond that, we'll talk about some things that you can do outside of the ER to keep your children safe.
Sure. So generally people come in 2 ways. One, they come in by ambulance, and usually we're alerted prior to them coming in when they come in by ambulance, and we'll have a room ready for them, and they'll go immediately to the room. The other is when they come by private vehicle, you're likely going to be asked by the clerk to get registered and kind of stand in line. I think there was a question in one of the emails as far as what do we do. I think you need to express to the clerk that your child needs immediate medical attention, understanding that most of the parents say that. If you tell the clerk they're having an allergic reaction, it's emergent, even say they could die, the clerk will understand what's happening at that point. To understand that the clerks are not usually medically trained, and this is in most ERs, that you have to get your point across to them that your child has an emergency at that time. Okay? And then once they're either, likely even before they're registered, they'll be taken to a room right away, seen by a nurse and an emergency department physician, and given, emergent medical assistance at that time. But I think, can I just add a little to this? I think, we never know when the children are going to have allergic reactions or where we're going to be, but I think if you have kind of a go-to emergency department that you visit that's close to your house or something like that, I would go talk with them and meet with them and say, my children have food allergies, are you guys aware? What should I say to you? How can I prompt you to let you know that my child needs emergent medical assistance? So I would encourage people to do that.
I think the nice thing about coming by ambulance is that all of us carry pagers, and we get a page with the age of the child, what's been given pre-hospital, if the ambulance the EMS providers have already given epinephrine, whether, kind of what the vital signs are. So it gives us just a few minutes to get the room ready, we can get the epinephrine ready, and that's definitely is the fastest way to have your child come in. And also if your child needs oxygen, they can do that in the ambulance. They can start an IV, and they can give more epinephrine if they need to. So.
I agree. And in addition to that, one of the things that people don't think about is if you're driving your anaphylactic child to the hospital, a couple things can happen. One, you're driving and you can't see them. So are they in the back seat? Are they unconscious? Are they breathing? Are they doing okay? So A, you're distracted because you're trying to keep an eye on your child and you're driving. And B, you may not be able to see them if you have them safely restrained if they're in the back. The other thing that's pretty frightening to think about is, and I've heard a couple of instances of this, not here, but are that people are driving someone with an anaphylactic reaction to the hospital and they get in an accident. They're distracted. It could be someone else's fault. Anything happens. Well, the EMS gets there thinking that there's a trauma happening, and they don't realize that the child isn't breathing, or the adult isn't breathing because there was an anaphylactic reaction. And if someone else isn't awake or conscious or able to say that that's what's happening, there's been a couple of deaths because they didn't know that there was an anaphylactic reaction happening. They thought it was a trauma. So I think you're better off at any point in time. And I know how scary it is. I live all the way in the mountains, and so to wait for that ambulance to come, that 10 minutes feels like an hour and a half, and it's a scary time. But I also know that they can safely get my child to the emergency department. Whereas I likely couldn't, because I'd be driving, looking, trying to check. You can't administer epi as you're driving, all the different things. So coming by ambulance is definitely the best option.
Yeah, the big thing that the big point we'd like to drive home with our new pathway and the protocol and the mainstay for treatment is intramuscular epinephrine. And there's a whole lot of evidence towards the different adjuncts and different treatments and this and that. The one most important thing, as I think probably everyone here is very well aware, is the epinephrine. And that's why everyone carries the EpiPen. We don't ask parents to carry around a whole slew of other medications. It's because the one medicine that acts on all levels to treat anaphylaxis is epinephrine. All the other adjuncts, as we're going to talk about, have a role in treatment, but none of them have all the alpha and beta adrenergic activities as that is what helps you as far as like the breathing issues and keeps the blood pressure up while is essentially responding to the anaphylaxis. A couple other things that you will see when you're brought into the ED and things that almost happen kind of automatically. They should give the IM epi within 10 minutes. They should place the patient on some oxygen. That certainly helps the child feel a lot more comfortable. Positioning is going to be a thing you'll see as well, depending on clinical condition. In a lot of cases, we like to lay the kids flat because that kind of helps them to, in the event that their blood pressure kind of goes low, that helps keep blood flow in your heart and your brain. But kids who are vomiting, be aware that they're going to probably want to lay the child on their side. And for kids who are having really severe respiratory symptoms, laying them back is contraindicated. You would want them to be upright to kind of support their airway. So you give them the oxygen, the positioning, and then in most cases they are going to want to place an IV and give a bolus, and that's an important thing again. In anaphylaxis, your blood vessels are very dilated, and that makes you kind of relatively low on fluid, in addition to the fact that your blood vessels become very permeable, or they allow fluid to leave. So one of the most important things for us to do is to get fluid back in your blood vessels, and the quickest way to do that is to put an IV in and give a bolus or a large quantity of fluid there very quickly. And then as you can kind of see, I'm sure everybody here knows, so allergies, there's a spectrum. There's a lot of kids who have asthma along with having anaphylaxis and other allergies, and certainly breathing treatments that you would give for an asthma exacerbation is something that's on the table as well for somebody who's having respiratory symptoms with an anaphylactic attack. And then kind of these adjunct down here, and these are ones that you may or may not see depending on which hospitals you go to. There's not a lot of strong evidence for or against a lot of these medicines. Benadryl and famotidine, they both are histamine, antihistamine medications, and they help very well with like a lot of the skin findings. So that urticaria, that really itchy rash you have, can certainly make kids a lot more comfortable. They do not have a direct action on the swelling in the throat or the lowering of the blood pressure, or some of the things that are more scary with anaphylaxis, and so that's why we really emphasize that epinephrine is the #1 main treatment because of that. And then this one is a point of much contention, I think, is steroids. There's been a lot of studies done, and there's not been much found as far as steroids helping overall improve outcomes. The theory behind it is these are very strong anti-inflammatory medicines. They do not work immediately. The idea is that like within 3 or 4 hours, you give a dose of dexamethasone, for example, and it kind of calms down the body's reaction. And the thought is that may help prevent a rebound or that biphasic response where you have another reaction secondary to the initial anaphylaxis. And there just hasn't been a lot of strong evidence. There hasn't been a lot of strong studies. So they're like these randomized controlled trials, very difficult to do obviously with something like anaphylaxis. And so the evidence that's out there is not particularly great, super high quality evidence, but it hasn't given us an indication that steroids are helpful in the treatment. That said, a single dose of like Decadron, which is the dexamethasone, or this methylprednisolone, is not going to be harmful. Steroids, we all think of them as then they do have a whole slew of side effects when you're on them for long term. But a single dose, we get them all the time to children who come in with either asthma or croup. I would be willing to bet that right now in this moment in the ED at UNM, there's a kid getting some Decadron right now. And so we give it all the time. And a single dose is a very low risk medicine. We give it to all kinds of kids. And certainly in asthma and in a patient who has anaphylaxis and potentially asthma as well, there would definitely be a role for it. So there is evidence that it can help in certain instances. But for just pure like anaphylaxis, there's not strong evidence saying that it helps.
I think one thing that we see quite often, and Sarah can weigh in on this too, is that even kids coming by EMS who clearly have anaphylaxis often will get a dose of Benadryl and not epinephrine. So I think that's something that we need to work with our EMS providers to help them recognize anaphylaxis also. And it's never a substitute for epinephrine. Epinephrine has a lot, we were talking about the different effects, but it constricts the blood vessels, and it's the only thing that's going to help the edema, the swelling in the airway. It increases your heart rate and your blood pressure. And it also stops the release of the mediators that are triggering the anaphylactic reaction. And then the other thing it does is it is a bronchodilator. So with the the bronchoconstriction that causes wheezing and difficulty breathing in the airways, it acts as a dilator, and so it helps with those respiratory symptoms. So it does so many things.
Yeah, so we've seen that, like, generally speaking, ER doctors, they're pretty hip to like using epinephrine other than Benadryl, but we've had several reports from EMS where they will chastise or say something negative to a parent about having used Benadryl, and that makes it hard for us because we tell them like the half-life of Benadryl, I mean like the time that it takes for epinephrine to work in your body is so fast, and it will save lives, but Benadryl takes a lot longer and it doesn't save lives. But how can, like, are there any like ways that we can get EMS up to date? Are they like different, or like owned by different companies that have different protocols? Like,
I would think the ambulance is definitely the largest one. So I think just education, talking with their medical director and looking at their protocols. I think, and we'll talk about anaphylaxis action plans in a little bit, but I think also if you have that handy, you know, say, this is my action plan,
for my
child needs, or I already gave epinephrine, she needs another dose, or, you know, or I've given 2 doses and she needs another dose. So really pushing them. And generally a parent is allowed to ride along also, if you're able to, depending on whether you have to bring other children to the hospital. So, but I think education and talking with their medical director.
Yeah, I think it's that quickness. Like, how do we convey to, as like lay people, to what we see as a medical professional, what, like, we want to use epinephrine, not Benadryl, quickly. Like, I think having an action plan is a quick way to say, like, this came from my allergist. But like, how you explained it is great, but I think it might be difficult for lay people to be like, this is what epinephrine does. So like, how can we say that in like 2 sentences, or how can we
I
say
think that,
that?
I mean, epinephrine is the only medication that is demonstrated to be effective.
Yeah.
And that is first line treatment for anaphylaxis.
I think
So
that's a good, like, first line treatment, like, any EMS person would understand that, like, if you said, like, this is the first line treatment for anaphylaxis.
And you're empowered, so in medicine, there's not a whole lot of medicines where family is the one that triggers the treatment pathway. Asthma would be another one. But that is actually your decision, right? I mean, like, the interesting point is that there's very few in medicine where we just say, parents, here's some protocol, you give epi when you think you need to.
Yeah.
And so, same with asthma, right? Like, I would hope EMS would show up at the scene and be like, well, you got out an inhaler for this kid, what are you doing, you know? Like that's your prerogative, actually, and there's a whole lot of medicines, I hope you're not involved in coding people with cardiac arrest, right? but there's a handful of medicines that we turn it over to the family and we say, you're the one who starts us down this treatment pathway. You know, like well, hopefully we're doing that. Hopefully we do a good job, and your allergy specialist does a good job of kind of empowering you to be that person, because that is in your hands. And so I would hope you would think that you would be empowered enough to say, like, no, we made the decision based off of what the education that we received to give epinephrine, and we think that's the treatment. We don't think, we know this is the only treatment for a concern of anaphylaxis, and especially in kids who have a history of anaphylaxis, right? That's one of the ones where you look at all the criteria and everything, and it's just a kid who has an anaphylactic reaction and is having almost any kind of symptoms, give the medicine, you know? So that's one of the ones. I would really hope our EMS people are not coming to people's houses and shaking their heads about that, because we're teaching that you're empowered to give this, and we want you to have a very low threshold to give it. And a kid who has a history and now is looking like they're having anaphylaxis, give epinephrine. Like, you're doing it right, and I hope they would respect that. It's the same as asthma. There's a handful of other medicines where it's in the ball's in your court to initially start that treatment. You know,
Right, which seems just like so obvious, but then we still are getting reports that pediatricians, EMS, like even some, like, people are going to emergency departments in other parts of the state, and people are saying, no, you should have used Benadryl first. It's like, okay.
Can I chime in on this too?
But yes, thank you, and I agree with you guys, obviously.
I think there's a lot of knowledge that needs to be explained to, there's a lot of education that needs to be placed out there, but I think as far as EMS, if there's a concern with a specific person, that does need to be reported to, and in all of Albuquerque and Bernalillo County, it's Albuquerque Ambulance is the company, and I know that they are very serious about that sort of thing. The other thing to remember too is, they could easily forget is that you give your EpiPen to yourself or your child or whoever, and by the time they get there, you're gonna look great.
Yeah.
So your child's gonna look great, and you have to remind people sometimes they didn't look like this a minute ago. But I think if there's a specific instance of someone chastising or belittling or anything like that, that definitely needs to be reported, because I know, having a spouse who works on the other end with EMS, that they don't tolerate that sort of thing. A patient's emergency is whatever the patient says it is. So they have to take that, and they have to treat that person appropriately and effectively and go on from there. So at least for that corporation, I know that they take that serious. So. But if your pediatrician isn't listening to you, might be time to find another pediatrician.
Yeah, or have them crack open a book or something. I mean, that's pretty well established.
And there are the guidelines are so easy
Yeah,
to
very
find
clear.
from lots of different organizations. So as far as how long we typically watch children, generally it's in the 4 to 6 hour range. The guidelines, and there are European guidelines, US guidelines, Canadian guidelines, but typically you're in the 4 to 8 hour range. 4, I feel like, is really the minimum. And that really needs to be individualized. based on your child and your child's prior reactions. So how severe was the current episode? So did we need to get 2 doses of epinephrine? Did the child have respiratory distress, airway swelling? Just basically how severe it was, how well did the child respond to the treatment? Has he or she had a biphasic reaction before, or protracted is just a really long reaction? And then certainly things like comorbidities, and asthma is really the big one for children. Where does the family live? Are they in East Mountains or even further away than that? How quickly can they access care? So those are the things that that we use, and also just talking to the family. I've had parents say, you know what, she's had a biphasic reaction, I'm not comfortable going home, and we just admit to the hospital right then. Infants, I tend to admit, I've seen 6-month-olds, 8-month-olds with anaphylaxis, and what makes me nervous about them, they're vulnerable because they can't talk. They can't say their throat is closing or they're having trouble breathing. We might be able to see that or hear the wheezing. But also their airways are so tiny and they just don't have the same reserve as older children and adolescents. So I tend to admit all of the infants that I've given epinephrine to. But I think it's really important for us to be talking with families and seeing what their comfort level is and also just what the specific risk factors are. So, any other thoughts?
I think also too with if you don't know the allergen, if they've never had if they didn't have an exposure to something that you know that they're allergic to, or if they've never had an allergic reaction, then I think that plays a huge role in it as well. And I think it definitely depends on the allergen. My daughter's milk allergy, she's had multiple anaphylactic reactions to that, unfortunately, and done okay. But recently had a peanut exposure and had anaphylaxis and ended up in the ICU overnight. Did fine overnight, but it was a new reaction for us. She never actually had an exposure and required a lot more epi than she had with anything else, so she stayed over. So I think as your child or your family member's advocate, you can always say, we don't feel comfortable going home. I would never encourage a parent to say, we want to go now, they're better. Because the likelihood of them getting worse, even if it's just, the visible by the hives coming back, it usually indicates there's something more going on, but that's very high. After like 1 dose of epi, and then we wait 4 to 6 hours, and we've seen a lot of kids have that reaction again. A lot of times the reactions are, afternoon or evening time, so the parents want to go home and everybody's exhausted because all this adrenaline rush from going to the ER and the reaction, and everybody goes to sleep who's watching the child or the family member. So I think if they say that they need to keep you, it's not to be mean, it's not to make you suffer, it's to make sure that you're okay or your child's okay.
We talked about this. So generally, if it's a severe episode and if we're having to give more than 1 dose of epinephrine, those are the patients that we bring in. I would add to this young infants and having children with some of those risk factors that we talked about, having had a history of a biphasic reaction, severe asthma is another thing, and just I think it really is individualized, but these are ones that we would definitely admit for.
I have a question.
Yeah.
So if your child has asthma, I had a child that has asthma and he actually ended up having a biphasic reaction. I think it was like 4.5 hours later. But my question is, are usually kids with asthma more likely to have a biphasic reaction, or it just depends?
I think that depends. I mean, they're at risk for more severe anaphylaxis.
Uh-huh.
Oh, there's Alan. Hi, Alan. But I think that it's a risk factor for severe anaphylaxis, but not necessarily a biphasic
Okay.
reaction. The thing about biphasic reactions is that they can occur up to 72 hours later. And they may be different from the initial presentation, so that it could be different manifestations.
Okay.
So Matt and I, just in the past year and a half, decided that we needed to improve our care of children with anaphylaxis in the pediatric PD. And as part of that, we developed a pathway and a care set, so an order set, which standardizes the treatment and to help minimize errors and to expedite care. So just to kind of walk you through, these are the criteria here that are the NIA, National Association of Allergy and Infectious Disease. So any one of these, anaphylaxis is highly likely, but what we put here is use clinical judgment, because the patient may not fit this, may have a history of a severe peanut allergy and just might be starting to turn red in the face and maybe all over, but we're going to use epinephrine in that situation, even though that doesn't exactly meet this definition. So if anyone is screening positive, so we talked about patients coming by EMS are going to go straight to a room, but if you're coming through triage and you tell the clerk that you're worried that your child is having anaphylaxis, they will immediately get a nurse, and then the nurse will come to us, one of the physicians, and we do what's called a swarm, which is basically we surround the patient and just give immediate care, immediate assessment and care. And so the first thing we want to do is remove the trigger, so thinking about whether we need to wash the child's hands or face if there's any sort of peanut or anything like that on there. Also stopping any IV medication that we might be giving, something like ceftriaxone. Anything that we can remove, we would. And then the treatment is immediate epinephrine. We talked about some of these other things, 100% giving oxygen. We talked about positioning, putting the patient on a monitor. And then this is our decision point. So if we only treat with one dose of epinephrine, then we're going to monitor for 4 to 6 hours. And as you can see, we don't even have Benadryl, famotidine, the steroid on. This is our main page. I'll show you page 2 in a second. Because down here we have consider adjuncts. Because we want the focus to be epinephrine, and then right over here is our dosing. And then if they're not improved after 1 dose, then we're going to repeat that every 5 to 15 minutes for up to 3 doses. We talked about giving fluids if we need to. If the patient's wheezing, we give albuterol. They have stridor, which is a high-pitched noise that patients can make with airway swelling, or with croup, it's kind of a high-pitched sound like that. Then we'll use racemic epinephrine. And then down here we have those adjuncts. So we really want to de-emphasize those, and that's why they're on the next page. And then down here, if the child's doing it better at this point, we'll admit them up to general pediatric service or the ICU, just depending on the level of support that they need. And then if all of this isn't working, then we would start an infusion, so a continuous infusion of epinephrine through an IV.
What is racemic epinephrine?
It is just a form of epinephrine that we give through a nebulizer.
Are we all get a copy of that, by chance?
What's that?
Can we get a copy of that?
Oh, sure. Yeah,
Okay.
definitely. I'll send it to Charlotte.
Fantastic.
Email.
Thank you.
I have it already.
Oh.
Sent it to me. so.
Okay, you have it. And I can actually send the actual document, the document, it's a separate one for the pathway too.
Okay.
So what do you think about
So this is kind of the second page is kind of, that is the supporting page for the main. You can kind of see that what we're following as we go through is that algorithm. And this is just kind of our reference page to the various stuff. And you, of course, we're not going to be expected to know the doses. I don't know of any parent that comes in with like, I would like 1.25 milligrams per kilogram of diphenhydramine to give it 2 to 6 hours. But this is just kind of this gives you kind of an idea on the other side, what kind of the physicians and your nursing staff are kind of like looking at as they're making their decisions. These are all the medicines that can potentially be given, and it would be based off of whatever the clinical appearance is. So if we got a kid who's wheezing, then albuterol obviously is going to be on the list. For the kids who have a lot of like skin manifestations, Benadryl and the famotidine, the histamine blockers are excellent in just helping with those symptoms. As we've said, several times previously. That's not what's treating your anaphylaxis, but it certainly can help kids be a lot more comfortable while they're there for their 4 to 6 hour observation period. And then steroids if we feel like they're necessary, and certainly an example would be a kid who has asthma, potentially some asthma symptoms going on at the same time. Decadron would be something that would be very helpful to give. Kind of talked a little bit more like the removal of the trigger. And certainly that's a big important thing, because what we would not want, obviously, is for them, a child to be kind of sitting there with their jacket uncovered in whatever plant matter is what's causing the reaction. And so that's I think one thing that we don't always think of, or it's not the most obvious thing, but it should be one of the very first things that we think of is we're not sure what this is. Could it be something that's on you? Did you get into a plant that's causing you to have an allergic reaction or a chemical or something? And then the positioning we kind of talked about as well. This is another big deciding point. The default is going to be the patient laying flat, and that's because there's unfortunately a risk for having very low blood pressure when you have anaphylaxis. And if your head and your heart are at the same level as the rest of your body, that kind of helps to continue to keep blood flow going to your head and your heart. But in the event that you're vomiting, or in the event that the patient's having a lot of respiratory symptoms, then we would have to adjust the position accordingly. And then just kind of the signs and symptoms of anaphylaxis, and this is one of the trickier aspects of diagnosing anaphylaxis, is of course a lot of this stuff is, a lot of these symptoms are things that can appear with a lot of different diseases or illnesses, right? I mean, you see up there, so like abdominal pain, like that's very, there's a lot of different things that could cause abdominal pain. And so kids coming in with abdominal pain, and then maybe this, or a chest pain, we have all this up there because it kind of helps us put all the pieces together. And a kid who's been previously diagnosed, obviously that's a very strong clue, but some of these kids who come in for the very first time, that makes it tougher if they're having these very non-specific symptoms to make the diagnosis. And so that's why the criteria are kind of broad, and they cover a lot of different organ systems for that reason. When you have involvement of multiple organ systems, that generally tells us, okay, this is very suggestive of anaphylaxis, and let's go ahead and get the treatment started. And then the goals, and this is one of our big ones, the epinephrine within 10 minutes of arrival to the ED. So everything else can wait. The big thing is just getting you that epinephrine. We don't even need to, because it's given intramuscularly, we don't even need to wait for an IV to be placed. Let's get it drawn up and get a correct dose and give it. And then a couple of other goals that we've been working on is having improving kind of our discharge process, as far as making sure that families leave with the prescription for an auto-injector, and then that they have an actual anaphylaxis action plan in hand as they leave for when is the appropriate time to use the auto-injector, what should they be looking for. And then kind of the last thing there, that's probably one of the most important things we can do is making sure that they get referred to a pediatric allergy specialist, right? Because that's going to be kind of your advocate for long-term treatment. Hopefully you don't get to see us too many times in the emergency department. We're kind of the people that I'd like to think we're nice people, but we're not the people that you want to see all the time, right? But your allergy specialist is the person that is going to be, if you need to, depending on what medications you need to be on, and kind of tinkering with that, and then any kind of other co-symptoms that you might have. For example, asthma and allergy, anaphylaxis would be something that you absolutely want an allergy specialist on board managing that. And the goal is that you can kind of form this therapeutic alliance where you're working with your allergy specialist to the point that you don't have to come see us very often. And in the event that you do, that you felt empowered to be able to give medicine when you needed to, and to take the right steps to get EMS there and get your child to the hospital quickly. So those are the things we wanted to do in our putting this new kind of this quality improvement project that we felt like we could kind of do a little bit better, is kind of put those things into play, along with getting the epinephrine within the 10 minutes, making sure that when you do leave the hospital that you kind of feel like you've been well educated and well kind of empowered to manage your child at home.
We did talk with Charlotte and Lisa earlier about support and also just information for families. So we have the FAIR folders to hand out, and also information about your organization to help connect them to community resources.
Oh, cool.
So we just talked about this, but these are our goals for the pathways. So we wanted to just go over some myths about anaphylaxis. So we'll just talk about the first one. And the first one is it can't be anaphylaxis if the child doesn't have hives. And while children often and usually have skin symptoms, in about 10% of cases they don't. And those are the ones that are really hard to recognize because they may just be having wheezing, respiratory distress, and vomiting. So it may not be immediately clear to families or to us what's going on, and that can result in a delayed diagnosis, and then it can also delay the administration of epinephrine, or result in failure to give epinephrine. So, 10% don't have skin problems.
This is a big one. I think that one thing is if we haven't identified a trigger, I think that then it's hard to necessarily make that diagnosis of anaphylaxis. And, depending on the studies, there's some that say 20%. There's some that say even higher. It'd be like a third of cases. We do not find exactly what the trigger is, and I think that that does make it kind of hard because families come in and you're not certain. The staff can make a clinical diagnosis. But then in the end, when you're being discharged home, I think there's kind of that level of uncertainty that, well, what was, what caused this, and I think that everybody that can be kind of frustrating and kind of nerve-wracking that we don't know for certain. Food is far and away like the most common one in children. The other things to kind of consider, some medications and insect stings you can kind of see are certainly things that are on the list.
Latex is another one.
Yeah, latex being very high as well. But that's another one of the reasons to have the referral done to the pediatric allergist is nowadays we have a lot of pretty good testing that we didn't have access to a couple of decades ago, and there's kind of the ability to explore this a little further versus in the past it was kind of just a pat on the back and well, whatever you were doing, try not to do that, kind of a thing. Now they're able to kind of get some testing that can kind of narrow in hopefully a little more on kind of specific potential triggers for your child.